Good morning, everyone. We shall start with today's Jaipur surgical tutorial session. I'm Dr. Manmohan Rajput, third year MCH resident from the Department of HPP Surgery and Liver Transplant. We have been joined by Kapoor sir and we'll be starting. My patient, a 61-year-old gentleman from Bharatpur, Satya Prakash, came with chief complaints of jaundice for a period of 2 months, pruritus since 15 days, and upper abdominal discomfort and intermittent fever for a period of 10 days. On elaborating the history, patient complains of yellowish discoloration of urine and sclera for the last 2 months. It was insidious in onset, initially painless, progressive, associated with itching, which started from the extremities and currently now over the trunk for the last 15 days. Dull aching, epigastric pain since 10 days. This was insidious in onset, mild to moderate. The patient also had dull aching pain since 10 days, which was yellowish discoloration of urine sclera for 2 months, insidious in onset, initially painless, now progressive, associated with itching, which started from the extremities and currently now over the trunks for the last 15 days. Dull aching, epigastric pain since 10 days, which was insidious in onset, mild to moderate in intensity. Intermittent in nature, did not radiate to the back, not associated with meals or change in posture, and was relieved on oral medications. It was low grade, associated with chills, intermittent in nature, and relieved with oral medication. Also, of loss of appetite since 10 days and unquantified weight loss over this period. However, the patient does not give any history of recurrent pain abdomen, no history of jaundice. In the past, no history of abdominal dyspnea, no history of hematemesis, no history of low-grade fever, malaise, and joint pain before episode. No history of recent cases of diabetes. Patient does not have surgical history. He consumes appetite. However, appetite is reduced significantly. Previously, it was chapatis now per meal, but now only takes one. No history of substance abuse. No alteration in regular bowel habit once a day. Family history is not significant. I would like to summarize: a 61-year-old male with no comorbidities, have painless progressive jaundice since 2 months, pruritus since 15 days, developed dull aching, epigastric pain, and low-grade fever associated with chills since 10 days, also associated with loss of appetite and loss of weight. So actually, was now, sir, he had quit farming around 5 years back. Yes.
These have implications for counseling, implications for management. You have to assess whether the patient, how much the patient will understand when you explain the illness and the treatment, and socioeconomic status or reimbursement status when you decide about various modalities of treatment. For example, if you have to do palliation, whether you put plastic stent or metal stent, the cost is different, whether the patient can afford or not. So the occupational status and the socioeconomic and educational status is very, very important for managing. And because as a super specialist, you will have to not only diagnose but plan the management also. These things are important. Next, this slide, yes. So based on this history of yellowish discoloration of urine and sclera, what do you?
Sir, most likely jaundice. Surgical, from his history, since it's painless, progressive, and associated with itching, most likely surgical obstructive jaundice.
What other feature would be present in a patient with obstructive jaundice? As we discussed earlier, sir, this term surgical obstructive jaundice is probably obsolete now. It used to be used because at that time the palliation of jaundice was only surgical. Now it doesn't hold true. But very rarely you do surgical palliation. So although we all continue to use it, but the correct term is extrahepatic biliary obstruction or obstructive. Yeah. So what other feature should be or would be there, which you haven't mentioned?
Sir, high colored urine
And
acolic stools.
so you didn't mention anything about the stool color.
Yeah, so that's something that he did not mention in his history.
Then you should say that he has not noticed or he has not observed what is the color of stool. That tells me that you wanted to ask for it. From what you have presented, I would presume that you don't know that stool color is to be asked.
Yes.
So even if it is a negative history or a negative finding, you have to mention.
Yes, sir.
Okay. Yes. Yes. Now, itching. How many trunks we have?
Just one.
So what do you mean by trunks?
Now the trunk.
I mean, these are minor things, but again, as I say again and again, you are going to be the highest qualified medical person. You are going to be the highest qualified person in the society. You have to be very specific, very correct. Okay, next slide. What do you mean by no history of recurrent pain at abdomen?
Sir, in patient with chronic pancreatitis, there can be recurrent episodes of pain.
Recurrent episodes of pain in the upper central abdomen. As soon as you say that, I know that you are asking about either peptic ulcer or chronic pancreatitis. What do you mean by no history of jaundice in the past?
Sir, here we are trying to rule out medical jaundice. Hepatitis is a possibility, or
So then it should go to past history. You are saying history of present illness. In the history of present illness, he has jaundice. That is the presenting symptom. This would go in the past history. Go back to the previous summary. What is the spelling of pruritus? Is it pruritis? Is pruritus? Pruritus is one of the most commonly misspelled word in medicine. Vomiting is another. Ascites is another.
US.
Correct spelling. Go to the past history. Any other past history in a patient with obstructive jaundice? Something which happened in the past, which was a different disease, and now something else has taken over.
Chronic pancreatitis
That you already mentioned.
polylithiasis.
Yeah, so again, the recurrent history of, because initially you said it is painless jaundice. So I know that there is no pain in the present illness. The recurrent episodes of pain abdomen would probably fit in here. For polylithiasis. For chronic pancreatitis, it would still continue.
Yes, sir. So that's why the generalized statement. I wanted to cover both biliary
So you have to make a separate statement for both things. Here you would say that there is no history of recurrent episodes of pain in the right hypochondrium in the past. And if it was there, whether there is a change in the nature of pain, because now he is having dull continuous pain, which doesn't look like biliary colic. So all these statements that when you make, it automatically tells me that you have these conditions in mind. Yes. So whenever you have a patient with obstructive jaundice, and if you are thinking of malignant obstructive jaundice, for CA gallbladder, you have to give a history of biliary colic earlier. For cholangiocarcinoma, you have previous episodes of cholangitis, which would suggest an underlying benign disease like polylocal cyst or rarely primary sclerosing cholangitis. If you see a patient with periampullary carcinoma in a relatively young age, you have to talk of symptoms of polyposis, bleeding per rectum. The moment you mention that, I know that there is a correlation between FAP and periampullary. When you think of carcinoma head pancreas, you have to say there is no previous history suggestive of chronic pancreatitis. So the moment you mention these negative histories, I don't have to ask you counter questions. They should come automatically. No, so what is your interpretation on the history?
So, I would like to consider extrahepatic biliary obstruction. And since initially the jaundice was progressive and painless, then it has become painful, I would like to consider carcinoma head of pancreas or CA neck of gallbladder based on the current history.
What is the classical presentation of CA head pancreas seen in majority of
The pain.
60 to 70% of patients with carcinoma head of the pancreas have pain with jaundice.
Yes, sir.
If you have painless jaundice, you cannot mention carcinoma head pancreas as the first diagnosis. It is possible. It is not the first diagnosis. What are the common causes of painless progressive jaundice out of the malignant causes?
Periampullary
and cholangiocarcinoma. Yes. These are usually painless to begin with. Yes. Some texts mention that if you have pruritus coming before jaundice, it may hint towards cholangiocarcinoma. I don't know whether there is evidence for that, but it continues to be mentioned in textbooks. But if you have painless progressive jaundice, then your differential diagnosis, the order should be periampullary, cholangiocarcinoma of the neck of the gallbladder. In fact, in North India, you can even say carcinoma neck gallbladder probably is more common than cholangio. And lower down will come carcinoma gallbladder, fundus body, and pancreas. Because pancreas, as I said, 60 to 70, 75% patients will have pain. Carcinoma gallbladder, fundus, and body, again, 50 to 60% patients will have pain and jaundice. Yes. Okay. So, in most cases, based on history alone, it is virtually impossible to say which malignancy. But you can put them in an order. Don't try to make a diagnosis based on history. Very. Unless patient says, I have palpated a lump in the right arm, then yes, you can say that most likely either it is carcinoma gallbladder or lower end malignancy, because patient cannot differentiate between a distended gallbladder and a GB mass, which only you can. So based on history, usually it will be a malignant obstructive jaundice, and these are the possible.
Coming to general physical examination, patient was conscious and oriented, moderate to built and nourished, ECOG 1, PMI of 21.6 kg per meter square, was vitally stable at the time of examination with a breath holding time of 19 seconds. Icterus was present, no pallor, clubbing, cyanosis, or fetal edema. Left supraclavicular node was not palpable. Over the extensive surface of arms and on the trunk.
I usually don't insist on it, but I know that some examiners, I think maybe examiners insist that you should make a subjective assessment of the depth of jaundice. You say mild jaundice, moderate jaundice, deep jaundice, just as an observation.
Yes. Moving on to the abdominal examination. On inspection, the abdomen appeared flat. Umbilicus was central. No visible scars, sinuses, or dilated veins were noted. Right upper quadrant fullness was noted on inspection. No visible peristalsis. Hernial orifices, there was no visible cuff impulse, and renal angles appeared normal. Spine on inspection also appeared normal.
Why should a patient with obstructive jaundice have a visible peristalsis?
Gastric outlet obstruction is a possibility.
Visible gastric peristalsis can, although you should add that there is no history to suggest it. Yes, but theoretically it is possible. Any other?
Extensive peritoneal metastasis can also
malignant small bowel.
शादी कर दिया क्या? अच्छा, तो जाते ही घर पे शुगर बढ़ गई.
jejunal lupus.
CGB में भी these are theoretical questions. They are not related to the case. They are related to general. You should know. You are right. Visible gastric peristalsis, malignant small bowel obstruction because of peritoneal dissemination, and as Dr. Ajay said, transverse colon, which can be involved in both CA head pancreas and in CA gallbladder. But you should add that in this case, I am not suspecting that because there are no symptoms to suggest any.
Yes. Coming to the palpation of the abdomen, superficial palpation, no tenderness, no local rise of temperature was noted. Palpation, abdomen was soft, non-tender. Gallbladder was palpable in the right hypochondrium in the mid-clavicular line with intrinsic side-to-side mobility, and it moves with respiration. No other palpable mass in the abdomen, no hepatosplenomegaly. On percussion, the liver span was 14 centimeters in the mid-clavicular line, no evidence of fluid in the abdomen clinically, and normal bowel sounds were heard on auscultation.
Your description of the gallbladder complete. Again, many examiners insist that when you are describing the examination, you don't give the interpretation. You only give the findings. You interpret it later. So instead of saying gallbladder palpable, they would say that the lump palpable. The more you want to tell us about this lump, this description enough.
Usually we'll describe that as a pear-shaped
Say the shape
with whether it's tender or non-tender. Mobility, respiration,
which mobility?
Side-to-side mobility.
So you said intrinsic
side-to-side mobility.
Or
and then whether it's contiguous with the liver.
Description तो कहीं भी हो, चाहे लाइपोमा हो, चाहे गॉलब्लैडर हो, वो सेम रहता है. Size नहीं आपने mention किया, आपने consistency नहीं mention की. Again, I would say that I as an examiner may not insist on this. I start the discussion at the but there are still several examiners who will insist that your history and examination has to be as in ambiguous. So which means size, shape, surface, consistency, mobility, tenderness, whatever. Pura description. And also because from this, I cannot make out whether you are trying to describe a distended gallbladder or you are saying it is a gallbladder mass. Understand the difference? In a periampullary, in a pancreatic head cancer, in a GBC neck cancer, what you have is a distended gallbladder, which is taking the shape of gallbladder, which is smooth, which has soft to firm consistency. If it is tense, it will be firm. which has even side-to-side mobility in addition to moving with respiration. On the other hand, if it is the GP mass of gallbladder cancer, the fundus and body, it may or may not be taking the shape of gallbladder. It may be even rounded. It may be having irregular surface. It will be firm to hard in consistency. It will move with respiration, but it will not have side-to-side. If you had described all these features, it is easy for me to know what you are saying. Otherwise, I will have to ask proper questions.
It's minimal points that if you mention about findings of inspection, validation, it's actually 0 to 100 marks. So you have to cover 0 to 50 to start from up to 51. If you want that, you should start from 0. You will get maximum 35. But if you mention that you already scored 50, so now your points will start from 51 to 60 now, so you can get 60 up. So if basic is filled, then it is the upper level that demands.
And अभी इनके एग्जाम में एक लॉन्ग टेस्ट है, एक है, पर पहले 4 होते थे, तो उसमें I used to tell the students, in the first case, you present it like an MBBS. Second, अगर आपने वो अच्छा कर लिया, second case में फिर एग्जामिनर बोलेंगे ठीक है, खाली समरी कर. But from your side, you should not try to summarize. You should not try to cut corners. You should present the whole.
Coming to digital rectal examination, perianal skin is normal, no sinuses, fistula of hemorrhoids, external hemorrhoids, normal anal tone with adequate squeeze, finger glove stained with K. colics 2, no mass nodule palpable on per rectal examination.
Digital rectal examination is what we do with digital. The inspection also, it is per rectal. Which DRE is a part of per rectal. The per rectal examination includes visual, inspection, DRE, and some people would say even proctoscopy. In a relevant case, suppose it's a patient with bleeding per rectum or melena, then you should ask for a proctoscope. If it is not provided, you should say that I wanted to do a proctoscopy, but I was told not to do it, or it was not available, or patient not available.
The rest of the systemic examination was unremarkable.
What were you looking for in this?
Sir, wanted to hear the air entry, whether it was.
Why should air entry be problem in a patient with obstructive?
Sir, if it's a malignancy, there's always a possibility of malignant pleural effusions.
That will cause problem in air.
If there is significant.
What are the signs of pleural effusion?
So, on auscultation, there will be diminished.
What are the signs of? You start chest examination with auscultation. Just say examine.
The movement on inspection. It will be reduced at on the side.
Reduced expansion on the outside. Then palpation.
Palpation usually the pleural effusion.
ऐसे करके कुछ करते हैं.
Yes, sir. That is the chest expansion.
उसके बाद
Then the percussion will be followed by
dull note. And then the reduced ALP. So if you have to mention that, either you say normal or you describe the relevant findings. Most students have this confusion कि pulmonary metastasis में air entry वो हो जाती है या cough with hemoptysis होता है. No, the commonest symptom caused by a pulmonary nodule is dry, irritating cough. It is at a very late stage that hemoptysis occurs. More common than pulmonary nodule is malignant pleural effusion. उसके signs होते हैं reduced expansion of the chest, dull note on percussion, and reduced air entry at the base. वो बोलोगे तो मेरे को क्लियर है कि आप pleural effusion देख रहे हो. Most students commit this mistake कि वो standard बस इतना बोलते हैं. No focal deficit लिखा है आपने देखा तो regular सारी exam. Don't say what you have done. Say use like
summarizing 16.
it has happened. Student has said oh. S1, S2 had no normal sound, last S2 now उसके पास था.
Summarizing 61-year-old male with no comorbidities, peak of 1, having progressive jaundice since 2 months, pruritus since 15 days,
Peak of 1 history का part.
making epic gastric pain and low-grade fever in 10 days, with loss of appetite and weight.
पहले आपने history को
Yes.
again contains some examiners say central apparatus. Try to avoid using technical terms in your history as far as possible. But कुछ examiners थोड़े से
On examination, these with scratch marks over the extremities, distended bodies combination, stools on
Previous word use class. If you have the patient, you have to use the term patient uses. Jaundice, he doesn't know. So, pruritus, he doesn't know. Itching, he will see. Itching at the side. You tell the examiner that you look for itching at the side. You feel it is pruritus. All the itching in the arms, I feel it is pruritus rather than the itching in the inguinal region. Itching in the inguinal region is not pruritus. It's the point. So that's how your history tells you that you are in the correct direction. If you already pull pruritus, means already you know the history and somebody has already told you the entire story. All the history has to be words of
also include important negatives. You have included so many negatives. You are obviously dealing with malignant obstructive jaundice. So in the summary, you have to mention that there is no clinical evidence of metastasis. You have to say no left blood level, no ascites, no parietal nodule, no umbilical nodule. All important. पहले जब टेलीग्राम होता था, तो जब कोई बीमार हुआ तो टेलीग्राम भेजते थे, फादर हॉस्पिटलाइज बट एवरीथिंग इज वेल। खाली फादर हॉस्पिटलाइज लिख दोगे तो उससे तो बहुत सारे मीनिंग निकल आएंगे। Summary is important, relevant, negative. So here you have correctly said that you feel it is a distended gallbladder, not a GB mass. I hope that is what you mean.
Yes. For some cases, the patient was evaluated in a hospital outside in the form of blood investigations, USG abdominal pelvis. MRC, following which the patient was referred to Mahatma Gandhi for further management. Patient was admitted and underwent triple phase CT abdomen followed by left PTP.
Okay, so suppose he came to you first. What would you do?
So I would like to, first the clinical examination, I would like to get blood investigations, like the test and ultrasound.
What blood investigations?
I would like to do a complete LFT, creatinine. So I would want to know his hemoglobin status. Also, I would, since he jaundice, I would want to know his hemoglobin if there any clinical blood loss. So I would be by hemoglobin. The patient has to giving us
Most likely he is having pollen. I have to look at his status. In fact, for immediate management, that is even more important than hemoglobin.
and investigation. Left is obviously jaundiced. Will be suggestive of
Don't use that it is like, okay, certainly, definitely.
LFT because he's jaundiced. He just
So how is it going to take
the patient with subclinical cholangitis, limited enzymes of alkaline phosphatase.
to say that on hemogram, 50 counts are normal, but still we have subclinical cholangitis, which will be manifested by raise in the enzyme.
So looking at investigations, his hemoglobin was low. On initial set, which was done outside, it was 7.9. Total bilirubin and direct bilirubin were also elevated 10.4 and 6.58, with AST-ALT also being high 214 and 291. Alphos was also elevated. On subsequent follow-up, the AST-ALT
Didn't comment on the TLC.
yes, sir. TLC is normal.
That now you have to also tell us whether on this date did he have fever.
So he had low-grade fever, sir.
Say that although he had low-grade fever, but his counts did not suggest cholangitis, but the enzymes give a hint that probably he was having subclinical.
Yes. And then he was admitted with us and post blood transfusion. Post blood transfusion to diabetes, he was 10.2. And by the time we had done a PTBD, the left PTBD, his total bilirubin and direct bilirubin was 3.9 and 2.9 respectively, with OTPT being, AST and ALT being 160 and 120. and alkalos was 307.
Also comment on his low serum albumin.
Yes, sir.
Initially it was 3.8, but that you should say was probably because he may have been dehydrated.
Yes, sir.
Once he hospitalized,
In hydration, his
hydrated,
albumin was 3,
his
sir.
albumin falls down to 3.8 and 3, which indicates that he has a poor nutritional status. Many people who take the serum albumin level as a kind of marker to decide whether a major surgical procedure like PD or TB can be done, or how much will be the risk, or whether we need to provide perioperative.
Yes. His tumor markers were within normal limits.
What does that mean? They love malignancy? No, sir. Say that.
They're just
Although I was expecting the tumor markers to be elevated, but they are normal. But it is no. See, MCH exam is not a question answer. It is an academic scientific discussion. Whenever you say something, you have to describe, you have to elaborate, you have to give your opinion. And then if the examiners don't agree, they will question. Let it not remain, मैंने एक सवाल पूछा आपने जवाब दे दिया, मैंने एक सवाल पूछा आपने जवाब दे दिया. That is not what an MCH should be.
yes. It showed a grossly dilated CBD with hypoechoic focus.
And you should know an approximate proportion that how many patients with CA pancreas will have a normal CA19. How many patients with CAGD will have a normal CA or CA19? How many patients with HCC will have a normal CA19? Rough numbers you should.
USG showed a grossly dilated CBD with hypoechoic focus of 13 by 11 mm, seen at the junction of mid and distal CBD, causing proximal dilation and abrupt narrowing of the distal CBD. Proximal CBD is filled with echogenic content, likely sludge. It also showed an over-distended gallbladder.
What is your mention the diagnosis? Will you mention as well?
Sir, dilated CBD with
That is not a diagnosis. That is a finding.
Sir,
What will you mention as the diagnosis?
based on this ultrasound, it looks like a lesion in the CBD only. Sir, most like
What will you mention as the diagnosis? Mid CBD
cholangiocarcinoma. Sir.
Lesion is at the junction of mid and distal. GB is distended. अगर cystic duct के ऊपर होता तो
GB would not have been distended.
GB distended है, so the diagnosis on this ultrasound will be a mid CBD.
And Mars outside. This is the image that is available. The image on the right is the PTBD gram that we had obtained at the time of PTBD insertion.
So what is done first? MRCP?
MRCP was done first. It was done outside.
Read the MRCP.
Here, the right and the left duct are coming together. The confluence is patent.
Where is it? Ducts तो white दिखनी चाहिए.
There is
तो दिखते नहीं है. Why we don't see the ducts as white? सामने क्या report किया था?
CBD में yes.
और क्या report किया?
Sludge.
Sludge. So then, why ducts are seen as white on T2 weighted image? Because of the fluid. If the fluid is replaced by solid, you will not see them. In fact, if you see carefully, this जो rounded दिख रहा है, हाँ, yes, maybe sludge. I'm not sure, but it may be. उसके बाद में जो दिखती है,
the more clear that it is diabetes.
so this is the fallacy of MR, that if there is sludge, you will not see, and this is of importance in a biliary stricture. What appears like a type 4 stricture on MRCP, that two ducts are separated, actually may not be type 4 because it is the sludge. That is the one fallacy. The other fallacy is that if there are two ducts which are separated, but you are seeing in a projection where they are overlapping, so it appears as what appears as a type 2 or type 3 stricture actually is a type 4 stricture. That is why a PT, PD or a PTC is definitely a better delineation, but we don't do it obviously because it is invasive.
Here, see the left and the right ducts are both dilated. Sir. There is bilobal ISBR3, and they are coming together, forming a confluence. And so it is difficult to say in this.
This is the best way.
Yes, sir. This is the best way.
But it appears as if there is a common hepatic duct. You see another globular structure, whether that is the gallbladder. So again, most probably the same findings as we probably saw on the ultrasound. The block is at mid CTVD level, although it's not a very good film. but it is, you can say that this is not a high level.
because the company
Which was not very clear on the MRC.
MRCP.
MRCP में confidence उतना अच्छा नहीं दिख रहा है. Retrospectively or based on ultrasound, it is probably because there were such fluxes.
That's what MRCP. The problem is that MRCP is done by the technicians. And they do only single T2N image, what they have been doing for all colleges or for all CBD obstructions. But to see a sludge and say, suppose they want to show a stent, they can show the stent with the same CBD by just changing the sequencing. So it is a complex study in which you have to grade how much of T1, how much of T2, what degree of variation you have to do. By that you can see everything. But problem is that they just, because of the workload, they do all the MRs in one day. So the technician does it. If you put your input, you can get the image very good on this also. So therefore, MRCP is like a sonograph. How good a sonologist is, he can show everything. MRCP, how good a radiologist is. This is the first MRCP of in the country was started at SGPGI by and this is his statement which he gave in 2002-2003. I'm still quoting it. He used to say it is not a statement that you can do everything. You need a brain into it when it is being done. अब आपको ये देखना है, अब आपको ये देखना है, so you keep on changing. So therefore, he is the most brilliant MRC person in the country. So same thing, in the same MRC, he could have shown the same choreograph. Somebody required.
Yes. That is why many centers, not most, but many centers for jaundice, especially extrahepatic biliary obstruction, they do a one-stop investigation, which is MR, imaging, cross-sectional, MRCP and MRNG. It gives you all the information which you require, and they don't do a CT. But for practical purposes in our setup, what I say generally is that for high biliary obstruction, which is cholangio, hilar cholangio and CHED, probably MR. For low biliary obstruction like periampullary and pancreas, probably CT. But in CHED, you may need a CT also in addition to this.
But in the single stop investigation, that MR. Suppose somebody asks you one investigation, that would be MR. It's going to show everything that will come. But you need a good expert to do.
Yes. MRC report says GB is over distended filled with sludge. Cystic duct is visualized normally uniting with CBD in the upper third. Ill-defined heterogeneous lesion 18 by 7 mm, seen involving mid CBD, leading to its abrupt narrowing and proximal dilatation. Proximal CBD showing sludge in its lumen. Moderate bilobar IHBRD is seen. Distal CBD is normal in caliber and wall thickness. The lesion is iso-intense on T2, hypo on T1. Post-contrast scan, no abnormal enhancement. Few lymph nodes are seen in pericable and outercable regions. Member is normal in size, shape, and signal intensity.
Go to the MR image. You can see the normal CBD door. This is the normal. So this means this rules out a lower end cholangiomas. Periampullary. That is one. Second, go to the MRCP report. What is missing in the report? PD be dilated in a mid CBD cholangio. We are not talking of lower end cholangio. Even in lower end cholangio, it is only in ampullary carcinoma that PD will be dilated. If it is a true lower end cholangiocarcinoma, PD will not be. What will decide the resectability of a mid CBD cholangiocarcinoma?
The proximal and distal.
What decides the resectability of a mid CBD or a hilar cholangio? Which structure, if it is involved, hepatic artery, they have no, it's a large tumor for a mid CBD cholangiocarcinoma. 18 mm is a very large tumor.
But usually we will not mention the vascular.
So that is what I said. It has to be MRI, MRCP, and MRNG. Because in hilar cholangio, in CHGB neck, in mid CBD cholangio, most important thing is the vascular involvement. So I presume that since they haven't mentioned, because contrast diya hai unhone, yes, it is normal, but it should be specifically mentioned. If they haven't mentioned, you should say, I would like to know whether the proper hepatic artery and the main portal vein are involved or free.
Portal vascular anatomy, they have not mentioned. Pancreas is normal, MPT is not dilated, no fluid collections, spleen is normal, no bacterial ascites. So we got a triple phase CT done at our center.
Why did you do a CT? What What did you want to do?
So not only does it help in establishing the diagnosis, it will help in staging of
How the CT establish the diagnosis?
it can be used as an adjunct to MRC.
So what more information?
So staging, it will help in the staging the site.
Site तो उसमें पता है flexibility
Yeah, but association with the vascular structures is
not
not
say that since the MRCP did not report the vessels, I want to see the vessels.
Yes.
So ideally they should have shown the vessels.
Yes.
But for biliary anatomy, MR is definitely better than C. Not just keep watching. You have to
Yes, sir, I do not. So the RHA and the LHA both appear to be free, sir. From there's no obvious mass that can be ascertained on the arterial scan, and the
You
RHA.
expect to see the mass on artery.
No, sir. No, sir.
Don't comment on that. Just say that the vessels origin is normal.
Yes, sir.
Their course is normal.
And they're
You are
not
more interested. Which arteries are you more interested in?
the RHA,
Why are it?
the cholangio, sir.
कौन सा cholangio है? तो mid CVD में RHA क्यों होगा? Which is most important vessel in a mid CVD cholangio? It is the proper hepatic artery. अगर वो involved है तो फिर तो खत्म हो गया ना, unless you believe in arterial reception.
Yes.
HA may be involved because it crosses the CVD
Long length of the region.
But then you can always do a right hepatectomy.
Yes.
More important is the in a hilar cholangio, which is usually on the right side, left is more important.
Yes.
If left is involved, becomes an unresectable lesion.
Right and left both are free here.
Most of these tumors will be seen in the portal venous field.
Yes.
Which tumor will be best seen in the arterial fields?
Neuroendocrine. The course of the portal vein also appears. Okay, sir. And there is a there's a disruption there's an abrupt cutoff as soon as the CBD is around the suprapancreatic or duodenal level. So there's bilobar IHPR with dilatation of the CHD-CBD as well. But
You see any mass lesion?
no mass lesion, sir. Mass lesion cannot be appreciated even on the venous space.
So while you are going through these cuts, you should say no specifying lesion
In the levels, yes.
no SITs.
Bilobar IHPR, dilated CHD-CBD, and then so the confluence is formed. Here, so at the level of the suprapancreatic or duodenal, there is an abrupt cutoff. The CBD is then not
From the CT, are you little worried about the level of obstruction? We know that it is below the cystic duct.
Yes, sir.
What makes you worried? The obstruction is at the place where the CBD is just entering the pancreas, which means you may have to do a PD.
The level of
True mid-CVD cholangiocarcinoma can be treated by excision of the extrahepatic bile duct.
yes.
After you demonstrate that both proximal and distal margins are negative. Here, it appears that CBD is involved till the place where it is entering the PD, which means that you may not be able to get a clear margins, which means that you have to be mentally and logistically prepared for a possible PD.
Reading the reports, there is diffuse thickening and enhancements of the wall of CBD in the suprapancreatic level, causing marked luminal occlusion and dilatation of the proximal biliary system. Length of the lesion is approximately 17 to 18 mm. Distally, CBD appears collapsed. PD is not dilated. Biliary confluence appears patent with bilobar IHPRD. Diffuse mild gallbladder thickening is also seen. No obvious infiltration into adjacent portal vein or superior mesenteric vessels. Multiple lymph nodes in the portocable peripancreatic regions around 9 to 10 mm. Small lymph nodes in the aortocable left paraortic regions and along mesentery. Largest measuring around 8 to 9 mm. Liver shows simple cyst approximately 10 mm in segment 6 and 7. Prostate is enlarged, diffuse mild urinary bladder thickening, no obvious dilation of small bowel. Kidneys are normal.
What is your analysis or interpretation of the CT scan?
Sir, so this is a lesion which is originating at the level of the mid CBD, extending distally. The important vessels in the regions appear to be free. All major,
You have to name the vessels.
the right hepatic, left hepatic, common hepatic, portal vein appear to be
Common hepatic.
proper hepatic cells. Proper hepatic appear to be free from the lesion. There is no portal vein involvement. There is no evidence of any metastasis. There are no space-occupying lesions of the liver that we need to be concerned about. No ascites, no significant lymph node outside the local region of the lesions. So it appears to be a resectable lesion. Since it's extending into the distal part of the common bile duct, one must take into consideration the possible need of pancreatic urogenectomy in this particular patient.
Most probably.
Either a simple excision of the bile ducts will not, hepatic bile ducts will not suffice.
Say that based on CT, it appears to me that the mid CBD lesion, because it is a long lesion, it is extending most probably into the intrapancreatic part of CBD. So in all likelihood, I will have to do a PD, so that I will not get a real.
Yeah.
But in any MR, if there is obstruction beyond that, there is undilated CBD. How can you say what is the discipline?
Next CT medical. That's yes, CT किया है.
अच्छा, it is going into the, there
Looks as if the intrapancreatic उन्होंने भी report.
study into the
No, they mentioned that suprapancreatic. Distal CBD is obscured. It appears to be collapsed on CTS.
आपको डिस्ट्रीब्यूट मिल जाती है ये भी बना नहीं है ना उसका तो एक rest of the CBD excision नहीं
So your approach would be that first I will do a CBD excision, supraduodenal, send the distal margin home, which if it is positive, then it is Anybody who wants to ask anything, any student, please unmute yourself and ask. Okay, thank you.
We'll end the session. Thank you.